So why do we still need an oscillatory trial? Before I get into the aspects of a trial and why we're going to study, I'm going to do an overview just about oscillation itself and what data we have, or should I say, what data we do not have. Disclosures, none of those are related to oscillation. And my objectives are to review the literature in relation to the use of high-frequency oscillatory ventilation for pediatric ARDS, to consider what remains unknown, and there's quite a bit that is unknown, and at the end we'll discuss an upcoming randomized controlled trial that will actually start hopefully tomorrow. So I'm going to start with a clinical case. It's a 4-year-old with H1N1 ARDS. He or she is being ventilated with SIMV ventilation, pressure control, pressure support, rate of 30, pressures of 24/12, and 70% oxygen. The blood gas you can see on the screen with saturation of 88%. The question comes in is, given all the data that you have and that you know of, would you consider a trial of oscillation prior to considering ECMO cannulation? So obviously it's a small group, we can interact a little bit. How many here would try an oscillator before cannulating? So I think most of us would, and I would. But if I went to the next room over, wherever all the adult folks are, and asked them the question, that's the response I would get, right? They'd be like, yeah, right. Well, let's go through the data and kind of think why this difference, why this discrepancy. And the truth is, we really don't have data, at least in peds, to really answer this question, and I'd actually raise the issue that in the adult data, I don't think the data are quite good. So with that, where are we today? The answer is going to vary, and again, no definitive data. So if we go back almost a decade now, 2010, at that point, everyone was oscillating. All of us ped intensivists were oscillating, adult intensivists were oscillating, and I just put this one study up from the British Medical Journal, because it was one study, a meta-analysis, that concluded that high-frequency oscillation was probably effective for ARDS, adult ARDS. And then suddenly, in 2013, comes Oscillate, and the whole world changed, and all of a sudden, all of our adult intensivists took their oscillators and put them in the closet or sold them. Well, what's the issue here with Oscillate, and why do I stand up here and critique Oscillate and say that in peds, I'm not so sure that that really is the answer and that we don't know the answer? So Oscillate concluded, and Neil's here somewhere, I just saw him this morning, that in adults with moderate to severe ARDS, early use of the oscillator as compared to with a ventilation strategy of low tidal volume, high PEEP, does not reduce and may in fact increase hospital mortality. See a study like that, it's in the New England Journal, it must be real, let's stop oscillating. Well, we got to look at the data and look at the data in a little more detail. So the purpose of this slide right here is highlighted is to look at sepsis. About half of the patients in this study were septic, and 2/3 of them were an inotropic vasoactive agent, some as many as 4 agents. So when you think about oscillation, which populations would you never oscillate? You would not oscillate asthmatics, okay, not applicable here, but you also would not oscillate hemodynamically unstable septic patients. Because what happens when you have a hemodynamically unstable septic patient, you put them on an oscillator, you turn up the mean airway pressure, they're intravascularly deplete, what happens to them? They die. And that's exactly what happened here, in my opinion. The other part, and this just shows that in the oscillator group, almost all the patients were on high frequency, or on vasoactive agents, and some for as many as several days. Well, the Oscar trial was sort of guilty by association. Same issue of New England Journal, back-to-back articles in that issue. Oscar's a neutral study. It says that oscillation is equivalent to conventional lung potential ventilation. It's just another mode. Use it if you want, don't use it if you don't want. But it's been guilty again by association, where people take this study saying the oscillator is problematic, the oscillator is something that we should not be doing. Oops. There we go. And also in Oscar, it's important to point out that in this case, not quite half, but 40% of the patients were septic and on vasoactive agents. So when we look at this, we move on, the last adult study that I'll show you, and this is a meta-analysis published here in the Blue Journal. And what we look here on the top part of this slide is the mortality in trials where the control group had tidal volumes of less than 8 ml per kilo. If we look at the forest plot, no effect on mortality. And down on the bottom, if you look at all trials, mortality, no effect. So the conclusion of this meta-analysis is if you really look at all the available data for adult ARDS, the outcome is the same. No difference between oscillation and lung protective conventional ventilation. So I think in many ways we really don't know, and the adult colleagues who have laughed and put the oscillator in the closet because of Oscillate may have done so prematurely, because I'm not quite sure we really know the answer. Unfortunately, given my 20-minute time limit, I don't have time to go through all the nuances of Oscillate, but beyond the septic approach, there's also other problems with that study. One is it was a one-size-fit-all mindset where every patient was managed the same without respect to that patient's individual pathophysiology. And such an approach, we know, doesn't really apply, that every patient physiologically is going to be different. Pediatrics, as I started out, there really are no data. I mean, all we have is John Arnold's study published now 25 years ago in Critical Care Medicine that did show the oscillator patients who survived with less chronic lung disease than the conventionally ventilated patients. However, given the high tidal volume in the control group of 1994 and prior to 94, we really can't make any comments today. So truthfully, we do not have applicable data. Often intensivists, peds intensivists who critique oscillation will talk to this Gupta study published in JAMA Pediatrics. The conclusion of this study was very similar to Oscillate. Application of oscillation and early oscillation specifically compared with conventional ventilation in children with acute respiratory failure is associated with worse outcomes. The results of the study are similar to the recently published studies in adults comparing these modalities. Well, when you look at the study, this is a propensity scoring analysis. This is a cohort study using an administrative database. And with that, there are very few clinically relevant data. I share with you this editorial from Martin Niebuhr. Martin really does a nice job critiquing this one study. And he says that the conclusions are too bold. It's retrospective, observational. There are numerous types of biases. The methods face serious criticism, specifically the use of propensity scoring with non-clinically applicable variables. They chose incorrect covariates for their propensity scoring. The variables had little effect on the decision to start oscillation, troubles the discussion, and lastly, no reason to abandon oscillation. So again, not a lot to go on in pediatrics. So with that, let me actually go through one study that I think really helps, and it really changed my view of oscillation. Before I do that, I forgot I put in this PLEAK slide. So PLEAK, the Pediatric Acute Lung Injury Consensus Conference, published in Pediatric Critical Care in 2015, recommended that high-frequency oscillatory ventilation should be considered, doesn't necessarily say it should be recommended, but at least considered as an alternative ventilatory mode in hypoxic respiratory failure in patients whose plateau pressure exceeds 28 in the absence of clinical evidence of reduced chest wall compliance. We should consider oscillation for those patients to moderate to severe pediatric ARDS, and of the 25 experts in PLEAK, 23 agreed, and just of note, the 2 who disagreed actually came from the same center. Okay, so this is the study I want to get to. This is the Bateman study. This was published in the Blue Journal in 2016. This is a secondary analysis of the RESTORE study. RESTORE was the 2,500 patient study looking at sedation management, nurse-controlled algorithm versus standard of care. That study showed no effect on total length of ventilation. But this post-hoc analysis took the 300 and something patients out of RESTORE who were oscillated and analyzed those oscillated patients. Okay, so it's not a randomized control trial, it is a secondary analysis. But the lesson here is really quite telling. So what we're going to do is we're going to take those 300 or so patients and divide them into quintiles. Shown on the slide are quintiles 4 and 5, the most severe of the 2 most severe groups. So if we look at this, we have quintile 5 and 4. 5 is the red line and the blue line. So be careful, the way the slide's displayed, you kind of want to compare red and black, but actually red and blue are compared, and the graph is showing length of ventilation. Red here is your oscillator group, red and blue is your conventional late oscillator. Stated differently, the quintile 5, and you'll see the same thing in quintile 4 when you compare black and green, are the oscillated patients who are on the ventilator longer. So for the sickest cohorts of patients, those patients that were on oscillatory ventilation compared to conventional ventilation were ventilated longer, although mortality is the same. If you don't like looking at it, a Kaplan-Meier curve, and you want to look at the actual data, here you go. Quintile 5, early oscillation versus conventional or late oscillation, longer length of ventilation. Same here in quintile 4, with mortality absolutely the same in the two groups. So with that, we have a situation where oscillatory ventilation led to the same outcome, but yet these patients were ventilated longer. So in many ways, it's an anti or negative oscillatory study. Coincident of finalizing that paper and getting it published, this is a real-life case that I actually got when I was in my ICU. It made me start thinking about this in a lot more detail. So I come on Monday morning, take over our ICU, and I got signed out for a 10-year-old, status post stem cell transplant, had idiopathic pneumonia syndrome, was on, quote, high oscillatory support, was now getting better. The blood gas you can see there, 734, CO2 of 52, and O2 of 70. Chest x-ray has pretty much essential resolution of bilateral airspace disease. Patients still on the map of 29 and amplitude of 45, 9 hertz frequency and 45% oxygen. And I'm told in my sign out that the team feels very strongly that the patient is improved, but tenuous given the history, that the patient was incredibly sick and we need to go conservatively. And the plan is to wean the mean airway pressure by 1 centimeter of water every 12 hours. Okay, well, it kind of hit me going, you're walking, you look at this patient who looks quite well, the x-ray is quite clear, and I'm thinking if you have a patient on conventional ventilation, how often do you sign out, I want to wean the PEEP by 1Q12? Right? The actual plan was just extubate her. And that's in fact what happened. Sedation was stopped and we extubated her the next day. So it really started making me and Martin Iber and other colleagues start thinking, the oscillator, boy, we're painfully slow at weaning this device, and maybe the problem is not the oscillator, but how we use it. And in fact, that is the conclusion of the Bateman study, is that after, let me see if I can go back. After adjusting for risk category, early oscillation use was associated with a longer length of ventilation, but otherwise equivalent outcomes. So we started questioning, maybe the problem isn't the oscillator, but it's the current use to oscillation. And in fact, we have to revisit how we manage the oscillator, which patients we select, and how we wean the device. So with that, I want to ask, what can we do differently? What can we do here to think about oscillation? Well, one thing is maybe choosing the right patient at the right time. And more data suggests that the oscillator is probably more effective in those with severe ARDS than less severe lung injury. We need to assess the readiness to wean mean airway pressure regularly, maybe do mean airway pressure challenges and mean airway pressure titrations like we do PEEP titration. We also need to consider true high-frequency ventilation and get away from the concept of resonant frequency and go with what's called corner frequency, and I'll come back to that in a subsequent slide. But corner frequency is the frequency which provides the lowest pressure cost of ventilation, the lowest risk of ventilator-induced lung injury. This slide from the Blue Journal, what we're looking at here is odds ratio, the green line here. Above that favors conventional ventilation, below favors oscillation. And what we see is a crossing point here at a PF ratio of 100. So those patients with more severe injury actually did better with oscillation, while those with less severe lung injury did better with conventional ventilation. Frequency, this comes back to the corner frequency I mentioned. Those patients with increased airways resistance, not that we oscillate those, really require a low frequency to exchange gas. But those patients with decreased compliance require a frequency of about 12 hertz to optimally exchange gas. And maybe the idea all along is that we've used too low frequencies in high-frequency ventilation, and we should be higher. So what I'm going to do with all that is bring this around to Oscillation 2.0, and I compliment Martin Iber for providing not only the concepts, but some of these slides. So from terms of optimizing oscillation, we should go with an open lung strategy and oscillate on the deflation limb. Do a recruitment maneuver in a staircase manner to titrate mean airway pressure to the optimal value and not just randomly set mean airway pressure and move on. to use the highest frequency possible, that being somewhere between 9 and 12 hertz, and to use a higher fixed power setting or amplitude, and using initial amplitudes much higher than traditionally managed, using amplitudes of 70 to 90. So this is a new approach. There are data to support this approach, and this comes out of Morten's unit in Beatrix Children's in the Netherlands, looking at 115 children over 3 years. About a fifth of them had severe PEDS ARDS. All these patients were managed with high frequencies, high initial delta Ps, and a staircase recoupment maneuver for mean airway pressure. And I'll share with you some of the data. On the left side here, we have mean airway pressures, generally in the mid to upper 20s. Red here is severe PEDS ARDS. Top right, amplitudes, generally between 70 and 90. And then the bottom right, frequencies hovering 10 to 12, but as high as 15 hertz in some of the severe ARDS patients. With that, across the top, we see OI on the left and PF ratio on the right. And oxygenation improves over time, especially with those with severe PARDS. And on the bottom, on the left, PCO2, on the right, pH. And we see that these patients are well ventilated despite using high frequencies of about 12 hertz and higher amplitudes. So we can exchange gas. Granted, it's hard to go through all the details of all these patients in a short talk, but I show you here on the top left, heart rate, top right, mean blood pressure, bottom left, central venous pressure, and bottom right, lactate. And taking all those data in composite, it appears that this physiologic-driven approach to oscillator management is safe regardless of age, patient weight, or disease severity. So with that, as I conclude in my last minute or two, comes the prospect study. Some of your centers are involved in this study. This is a study of both oscillation and prone ventilation. In the room, some of our colleagues and co-investigators with Simon Erickson from the Australia-New Zealand region and Jen Howe covering the Asia region. With this, for those who are not aware of the prospect study, it's a 2x2 factorial design, randomized controlled trial looking at severe pediatric ARDS with patients randomized to one of 4 boxes: conventional supine, conventional prone, oscillator supine, or oscillator prone. This will be about a 1,000-patient study in 45 centers around the world, including here in Singapore, again, several sites in Australia, New Zealand, Malaysia, Thailand, and the remainder of the sites are in North America and Europe. With that, I'm going to conclude. If there's questions, I'm happy to take them at the end in the panel discussion. And those who might want more information about the study, it's all on the website shown here. Thank you very much.